Good afternoon, everybody. This is your good old neurologist, Dr. Jeff Gelblum, coming to you today. And purpose of today's discussion is to give you an update as to what are the potential neurological manifestations, the neurological diseases that can come about as a result of the COVID infection. So we're going to discuss today how COVID can present in a neurological setting. I've been in practice for about 25 years now, so pretty much as a neurologist, I've seen most of the things that are out there. And I want to remind all of you that COVID-19 is basically a new virus, but it's the good old-fashioned SARS virus coming around with 2020 dressing, meaning it's a virus that we've seen before. We saw it back in 2003. And the coronavirus that we are encountering today, the COVID-19, is very similar to the viral attack that hit with SARS back in 2003. So if you are watching other Facebook programs or looking at Facebook posts and you'll see a resident from an emergency room in Montefiore Hospital in New York saying, in all my 2 years of residency treatment as a resident doctor in the emergency room, in all my 2 years, I have never, ever seen anything like this before. Well, that's all the more reason why it's good to take advice from an old neurologist like myself, because we've been to this rodeo before. And this is the old SARS rodeo. And the old SARS rodeo from back in 2003 looked very similar to what we're seeing today in 2020. So what was SARS back in 2003? Severe acute respiratory syndrome. That came from a coronavirus, very similar to the coronavirus that we have today. And in fact, if you look at the DNA composition, if you look at the genetic composition of the two viruses, there's extraordinary overlap. In fact, COVID-19, I think, has about an 80 to 90% similarity between the SARS of 2003. Don't quote me on the exact number. I don't have it in front of me. But suffice it to say that we neurologists have done this dance before. So for anybody who's out there, Chicken Little, the sky is falling, this is the end of the world, this is some brand new demon from hell, we've seen this before. And this goes back to 2003. Now, in the United States, we didn't see it to the same degree as it was encountered in the Far East. But SARS, COVID, 2003 is very similar to what we're looking at in 2020. Remember, these viruses come around every decade. So in 2003, we dealt with SARS, which was severe acute respiratory syndrome, and that was primarily stuck in Asia, didn't make its way here. And then about 10 years later, in 2013, we had MERS, Middle East Respiratory Syndrome. So 10 years after the initial SARS from Asia, there was the MERS in 2013, and here we are almost a decade later with COVID-19. So these coronaviruses are out there. They have hit different populations. Initially, the SARS was an Asian infection, primarily confined to Asia back in 2003. It didn't really make its way to Europe or the US. And then we had MERS, Middle East Respiratory Syndrome, which is also a coronavirus, and that struck back in 2013, 10 years after 2003. And then here we are a decade later with COVID-19, which is basically COVID-20, coronavirus of the respiratory ilk 10 years after MERS. So pretty much every 10 years, we as a human population are going to be having these types of corona attacks. And here we are, April 13, 2020, in the midst of a corona attack. But for anyone to say that they've never seen anything like this before, that, oh my heavens, this is some brand new infection from the depths of hell, no. This is a very typical corona syndrome because the SARS infections that we saw back in 2003, the way the infection looks nowadays is very similar to that. So that brings us up to the neurological implications of SARS from 2003, MERS, Middle East Respiratory Syndrome of 2013, and now here we are, 2020, COVID. They all look very similar from a neurological perspective. And what does that look like? Well, we know that one of the hallmarks of the coronavirus is its ability to get into the nervous system. And typically, the way that virus can get into the nervous system is twofold. It can either come into the nervous system by way of the bloodstream. So you get a corona infection, the infection goes into the bloodstream, and then that infection then works its way up into the brain. Or it can make a direct involvement in the nervous system by way, typically, of the olfactory mucosa. So what happens is if you inhale that viral particle, it can go right into the olfactory area of the brain, which is in the temporal lobe, deep in the brain area here, and it can make its way into the brain. So what does that infection look like? Again, it looks very similar to what we saw back with SARS 2003. So what it can look like is fever, obviously, as the hallmark, and then it can be confusion, headaches. Many of my patients who have a COVID-19 syndrome, who I treat a lot of, many of those patients complain of difficulty smelling or difficulty tasting. And why is that? That's because the virus, as it goes into the nose, irritates the olfactory mucosa, and then the virus can work its way up the olfactory mucosa into the temporal lobe of the brain. So what do these neurological diseases look like as relate to coronavirus? And again, we're talking about the whole family of SARS, we're talking about the whole family of MERS, Middle East Respiratory Syndrome, and now we're talking about COVID. So it's all under one umbrella. So for anybody to tell you, oh, this is brand new, we don't know what to expect, not true. We neurologists know exactly what to expect. So the three different types of presentations, neurological presentations of coronavirus as it stands now could be something as simple as loss of sense of taste or smell, or it could be something as complicated or as significant as encephalitis, a viral encephalitis. Now, we neurologists have dealt with this for many, many years. Viral encephalitis is something that doesn't usually kill. It doesn't usually cause any permanent disability. These types of illnesses respond to supportive care, as can involve taking care of the fever with drugs such as Tylenol, or if there is brain inflammation going on, using corticosteroids. Now, obviously, these types of treatments have to occur within a hospital. It's going to be hard to manage this at home. So if you're experiencing the beginning prodrome of loss of sense of smell, headaches, or loss of taste, that could be the beginning of a coronavirus as it impacts on the nervous system. But don't freak out. This is nothing that is typically life-threatening. But the disease, as we neurologists know it, can progress to a condition of a viral inflammation of the brain that we often take care of very easily in the hospital setting. So that's the first way that the virus can manifest with regard to brain functioning. The second way is by something called toxic encephalopathy, which means you're so sick in the body that you can't think straight in the head. And as I always say, it's hard for a car to run on 4 cylinders. So if you're not breathing well, and if you're febrile, and if you're having inflammation of the lung by virtue of the respiratory impact, the pulmonary impact of the virus, then obviously your brain's not going to be doing well, because at any point in time, the brain takes 20% of all oxygen in blood that the body pumps out. So it's a very greedy organ. So if the rest of the body's not doing well, then obviously the brain's not going to be doing well. So that's called toxic encephalopathy. And that just basically means you're sick as a dog because your whole body's sick. So the brain is sick, you'll have headaches, you'll have difficulty thinking sometimes, you might be a little bit confused, you'll have headaches. But again, this is reversible as the body starts to heal and as the body starts to respond and clear out the coronavirus. And then the third way that the brain can be affected by COVID-19 is with a cerebrovascular mechanism. And what that means is the virus has caused the heart rate to go faster, has caused the lungs not to give as much oxygen as they should be doing, the kidneys perhaps not to be working as well as they should, and as a result, there's not enough blood going to the brain. And again, all of this information that we're seeing now is really the same as what we saw in 2003, and again with MERS in 2013. So for any young doctor, that's why you always got to go to an old neurologist, because we've seen it all. But for any young doctor to tell you, holy smokes, we've never seen anything like this before, danger, danger, it's coming from hell. Not true. This is the same old corona story that we're used to seeing going back almost 20 years. So the third way that the coronavirus can cause difficulty with brain functioning is by virtue of a cerebrovascular component, meaning if you've got a history of stroke, or if you've got hypertension, high cholesterol, diabetes, vascular disease, and then you get sick, and I mean really sick, with corona, then obviously you can have brain disease or brain dysfunction on that basis. But again, this doesn't usually mean that it's irreversible brain damage. It's just that the blood to the brain, the oxygen to the brain is not going as well as it should. So as a consequence, the brain is not going to function as well as it should. So what we're looking at right now, us old neurologists, we've been to this rodeo before. And this is the old SARS rodeo from 2003, and then they dressed it up again with Middle East respiratory syndrome in 2013. And here we are again in 2020, same old, still typical corona manifestations and how they impact brain functioning. There is nothing really new here. So I don't want any of you to think, holy smokes, this is just a horrible condition. Humanity has never seen this before, and nobody knows how to respond. Not true. We know very well how to respond, and we neurologists have dealt with viral encephalitis before. We've dealt with brains not functioning well as a result of underlying toxic or metabolic disease, and we certainly know how to treat cerebrovascular disease. So what we're looking at right now is a rehash of what we've seen for the past 20 years, going back to SARS 2003, MERS in 2013, and here we are in 2020 with corona, COVID-19. But we're not seeing anything new. The way the disease is playing out is very similar to what we've seen before, and we've got a lot of good experience going back. The reason why you see so much alarm in the news media is because obviously we've got so many people that are being infected right now that they're overwhelming the health system. That's why it's very important to maintain social distancing so that we don't suddenly overwhelm the health facilities that are available in our communities, because if everybody gets sick at the same time, then there's no more emergency room beds or ventilators left. So that's always very important. So recapping what I just said, there's nothing new about COVID-19 as relates to neurological disease. We know that these coronaviruses can interface with the nervous system. We know that the way that they can get in is either through the bloodstream going up to the brain, or by direct insinuation through the olfactory mechanism, as that goes back into the bulb of the brain and the deep parts of the brain. So nothing new, and honestly, not a lot all that interesting for us neurologists who've been to these rodeos before. How does the virus get into the brain? Well, it can come in through the blood. It can come in through the neurons, meaning the nerve cells in the olfactory area can track up into the brain. Obviously, if you have difficulty breathing, hypoxia, meaning lack of oxygen, can cause brain disease, hence leading to the toxic encephalopathy or the cerebrovascular disease that we've been talking about before. Also, if your body is mounting a huge immunologic response, we call that immune injury, and that huge response, other people might call it a cytokine storm, maybe you've heard that term. That inflammatory process can also interfere with brain functioning. And then we know that the little corona spikes, the little spikes on the viral particle, can actually hit on certain receptors that line the bronchial tree, that line the lungs, that line the blood vessels, and those receptors are also on the brain. So it's thought that that could also be a mechanism of entry or of irritation of the nervous system. But again, I want to reassure you all that what we're looking at today has been seen for the past 20 years. We have seen this disease before. So we neurologists, we folks in the critical care setting, we know how to take care of these types of processes as they occur, and we have treatments available for it as it occurs. So for all of you who are trying to stockpile hydroxychloroquine or reading about new zinc ionophores that open up zinc capillaries to the brain, all of this is still unproven. The bottom line is we have an excellent capacity to deliver good supportive care for those patients who start to develop any types of serious manifestations, neurological manifestations of corona, as it may impact the nervous system. And I want to remind you, during the MERS outbreak, MERS, during the MERS outbreak in 2013, it was thought that about 20%, 1 out of every 5 individuals suffering from that corona attack had a neurological implication, a neurological manifestation. That's not to say that they're in a nursing home now, or they're vegetative or hemiplegic. No, it just means that this virus, which has a predilection for the lungs, also can have a predilection for the nervous system. And that's why one of the beginning features, one of the beginning symptoms of the coronavirus can be loss of sense of smell and sometimes loss of sense of taste. So again, nothing new. We've seen it before. I've been to this rodeo before, going back 20 years. And that's why if you take your advice from any professional at all, please take it from somebody who's been around for a while, like myself, who can say, yes, I've seen this, not to worry. Chances are this will go away when the underlying disorder resolves. And I can tell you the likelihood of developing any permanent neurologic injury from COVID-19 is remote. So therefore, it's important to understand that the underlying mechanism of the virus as it attacks the lung is very similar to the mechanism which can also cause a neurological impact. But we don't believe that this is leading to any irreversible, permanent neurological brain damage that would render anybody with any severe disability. So the 3 items, the 3 ways by which the coronavirus can get in to the brain are direct, usually through the olfactory area, and we call that a viral encephalitis. That's A. B, you can be so sick from the corona that the brain just isn't functioning well, and we call that toxic encephalopathy. And then 3, the brain can be deprived of oxygen and blood by virtue of the coronavirus's impact on the systemic metabolism, and that can cause some cerebrovascular dysfunction. So there's really only 3 things that we have to worry about. And I know you might say, holy smokes, 3 things, they sound terrible. But as a neurologist, we've dealt with these 3 things for years and years, and we do know how to take care of them. Mechanism by which the virus can get into the brain, again, blood by way of the nerves, by way of not having enough oxygen in the lungs so that the brain starts to develop damage on what we call a hypoxic basis. Immune injury, in case if there's a huge inflammatory response by the body, and that can sometimes occur in the brain as well. And then there's little receptors called ACE2, ACE2 inhibitors, which can allow the virus to enter into brain cells. So honestly, we neurologists have dealt with this before. As I've said, we've been to this rodeo back in 2003 with SARS. We were again invited to the rodeo again with MERS in 2013. And here we are again in 2020 with another coronavirus outbreak. Remember, these coronaviruses they've been in the animal population for many, many years, and they flip into the human population probably by virtue of they mutate to some degree. The original SARS virus from 2003 was an animal, called a zoonotic, an animal virus that then flipped into the human population. That came out of Asia. The Middle East respiratory syndrome, that was from bats and then went to camels and then went to humans. So Now we're dealing in 2020 where it probably started with a bat and then came into the human population by virtue of that mutation. And again, we've got to stop with calling this a Wuhan virus or a China virus. You know, we talk about the Spanish influenza of 1918. That didn't start in Spain. That virus started in an army camp in Kansas during World War I, but because there was a national blackout of news, because we had the World War I effort, it was never publicized in the United States. It was not allowed to be publicized. The only country that wasn't subject to a blackout was Spain in 1918, because it was the height of World War I. So they were reporting about this virus, hence the Spanish influenza. But it probably started in the United States. And in fact, you do realize that the high incidence of coronavirus infections now in New York probably have nothing to do with a Chinese involvement, but probably from a European involvement. So for us to talk about the geopolitics of a virus is absurd and makes absolutely no sense whatsoever. So if you want to talk about the Spanish influenza of 1918, we really need to rename that the Kansas influenza of 1918. It just happened to have been reported in Spain. So all of this is very important information because we do know that the coronavirus mutates. It's probably on this 10-year cycle. So what we're all experiencing now in 2020, we're probably going to see again in 2030. And the important information to keep track of is what is the communicability? What is the rate of infection from one person to other people as pertains to this virus? And that brings us to the next discussion point of today's Facebook Live. That's called the R0. In fact, if any of you read my post this morning, I was saying I was feeling a little bit R0. What is R0? R0 is what is the rate of infection from patient 0, patient 0. We were thinking that the coronavirus R0 rate was somewhere between 2 and 3. We thought it was really about 2.7, which means that if I were sick with corona right now, probably I could infect 2.7, 2 to 3 other people. That's what we've been thinking. And why is that an important number to know? Because if you know your R0, then you can easily calculate what percentage of the overall population is likely to be immune at any single point in time. It's a rather complex statistical calculation. I don't want to get into it, but with an R0 of 2 to 3, that suggests, based upon the statistical calculation, and that's pure science, folks. There's no politics here. An R0, which is what we thought about the coronavirus of 2 to 3, meaning one person can infect 2 to 3 others. An R0 of 2 to 3 suggests that you need 55% of the population to be infected to prevent the entire population from succumbing to the virus. That's a statistical calculation. Now we think, based upon the Chinese data, if you can believe it, maybe we can, maybe we can't, now we think that the R0 of this COVID-19 may be between 5 and 6, a little bit higher, meaning one person could theoretically infect 5 or 6 other people. If that's the case, then we would need 88% of the population, 88 or 82, don't quote me on the exact number. We would need in the 80% of the population to actually provide herd immunity, meaning once that population is immune, then there's virtually no likelihood of the disease coming back to any significant degree. So the lower the R0, the lower the amount of population that you need to be exposed in order to suppress the overall virus. With a higher R0, you need a higher degree of population to suppress the virus from coming back. We think that the R0 of coronavirus may be a little bit higher than 2 to 3. In fact, there's some data coming out of China that it might be 5 or 6, meaning one person can infect 5 or 6 other people. If that's the case, we are probably going to be looking at a greater degree of population that's going to be required for herd immunity. That is going to be an issue that our policymakers are going to have to figure out in order to figure out when to reopen the government and the functioning of any economy, be it here, France, England, Europe, anywhere in Europe, anywhere in Asia. So when we talk about the R0, we talk about the rate of infection from patient 0. Right now, we thought that the R0 was between 2 and 3. Based upon the Chinese data, it may actually be a little bit higher. And if that's the case, in order to get herd immunity, meaning in order for the entire U.S. to be reasonably certain that we're not going to get hit with this again, we'd have to probably have at least an 80% antibody positive rate, meaning an 80% rate of individuals that are immune, and that may be a difficult thing to achieve. So those are the facts as it stands now. Recapping, there's really nothing new about COVID-19 as relates to the nervous system. It's a coronavirus. It functions and has the structure and has the presentation very similar to our old friend SARS from 2003, and more recently our friend MERS from 2013. So we're at this rodeo all over again. Unfortunately, it's hitting with such a big impact in the United States that we're now having to learn about these terms called SARS and MERS. But suffice it to say, a coronavirus in many respects is a coronavirus. It attacks the lungs for sure. It does have a neurological implication, definitely. What we need to do is we need to get great data. We need to know the number of people that are actually infected, and we need to know the number of people that are antibody positive, meaning have seen the COVID-19 virus and have not gotten sick, because with that we can back in to the calculation of what's the R value, the rate of infection. And at that point, once we know the R0, we can calculate exactly what percentage of the population needs to be immune in order for the virus to essentially go away, to no longer be clinically important. But what I want to remind you is, this is not the last dance. We are going to see coronaviruses probably every 10 years. And that's the way the cycle has been working for the past 2 decades. So I anticipate that I'll be back with you again in 2030, probably older, more wrinkly, but even more experienced. And I'll say, hey folks, we did this cha-cha back in 2020, and here we are again, invited to this dance. And with that, I want to remind you again that the facts are so important. We've got to stop with these rumors, this fear-mongering, these Bill Gates conspiracy theories, these vaccination conspiracy theories, because the only thing that's going to get us all back to a state of good societal health and good economy is facts. And the facts that we need to have right now are the facts of how many people had it, and we can get that from an antibody test. How many people have had coronavirus exposure so far to COVID-19, and what's the incidence of it now, meaning who had it and who has it. If we have those 2 data points, and we can do this on a broad spectrum basis, if we have the will, with those 2 data points, who had it, who has it, we can back into the calculations of figuring out what is the rate of infectivity, and with that, we'll be able to calculate what is the required herd immunity for all of us to open up the door and say, I'm free, I'm back to work, and I'm ready to get going. With those facts, we will have the information that we need. Without those facts, we will still be in a zone of ignorance, and that's where we are right now. So for purposes of today's discussion, reminding you, we neurologists have done this dance before. We did it 20 years ago with SARS. We did it 7 to 8 years ago with MERS, and here we are today. The neurological implications of coronavirus 19, COVID-19, are very similar to what we have seen with SARS and MERS. Nothing surprising here, nothing beyond the realm of treatment. The reason why we must maintain social distancing, why it's imperative, is because if everybody gets sick at the same time, we will cause an instantaneous collapse of the health system in our country and in every other country. There's a lot of debate now about reopening the economy, but remember, the only way you can have a good economy is with good public health. If you have no health system, you have no economy. So therefore, we must do everything possible to preserve the health system integrity. And with that, it means not bombarding the health system with a huge upswing in corona severe illness that would quickly overwhelm our health system and cause its inevitable collapse. And that's hard to bring back. Once that system collapses, it's hard to regenerate an entire health infrastructure. So social distancing, still imperative in order to prevent the health system from being collapsed. I do understand that it's causing significant economic harm to all of us, but is it worth our short-term sacrifice to maintain preservation of our health infrastructure? I think it is, because without health infrastructure, we can't move anywhere as a society. Not even having to deal with corona. You have a heart attack, you have an infection, your kid has a tetanus attack, somebody falls into a swimming pool and has a near drown. Forget about it. Without a health system, everybody dies. So the information that I shared with you today is really twofold. First thing, to remind you that coronavirus 19, COVID-19, is no different or very little different than what we've seen with SARS and MERS going back to 2003 and 2013, and that the way it impacts the nervous system is predictable. We've seen it before, and we can treat it. And then the other information is that data must be collected so that we can calculate the R0, meaning if we know who has it and who had it, we can back into the R0 calculation, and with that we can figure out how many people have to be immune for the disorder to go away. And we can calculate that. All we need is a little bit of information, and hopefully we'll get to it in not too long. And then, of course, I want to remind you, we don't call it the China virus. We don't call it the Wuhan virus. Unfortunately, we've been calling it the Spanish flu from years ago, but that virus started in Kansas, brought to Europe by soldiers during World War I. Those soldiers were under propaganda blackout, so the only country that could report that was Spain. So we've got to get rid of the politics and just go to the basic science, the basic facts, the basic statistical truth that will really set us free in allowing us to get back to work in a good state of health. There are no questions at this time, so I want to thank you for your attention, and I look forward to meeting with you again real soon to give you another COVID-19 update. And remember, if any of you are experiencing any neurological signs or symptoms that you think are attributable to COVID or anything else, our office is available and eager to help you, and that would be by simply scheduling a televisit. So I look forward to talking with you again real soon. I hope that this was useful information, and I want you to all stay safe and socially distant and factually aware, because honestly, the truth will set you free, and the facts constitute the truth. And those facts are usually irrespective of politics, of religion. They are pure science, and the science we've pretty much got. So I look forward to seeing you again real soon. I wish you all a great day and good health to you all. Happy Easter, happy Passover, and upcoming happy Ramadan. Have a good afternoon.